Hello everyone, welcome back to the continuation of our public health dentistry question paper discussion. So last session was part 1 where we discussed the beginning 3 chapters and the water purification and waste management. And today's session, part 2, will be dealing with the most important chapter of public health dentistry, that is general epidemiology. So epidemiology is not just important for your exam, it is also a very important tool for you to do the research when you are going abroad for any public health courses like MPH or other masters courses in health sector, or even you are doing an MBA or any other that kind of courses, or even if you are going for a post graduation after BDS, you would need a thesis research, that is a research project in your postgraduate curriculum, where you need all these principles of epidemiology, the concept of epidemiology. So you would definitely need this chapter for your future career if you are to stay in dentistry as a research person. So general epidemiology, while coming to our exam point of view, definitely 1 or 2 questions will be there in each exam. Mostly it will be an essay, and many short notes and short essays being asked from this chapter. The chapter is the most complicated one, but once you get the core principles of epidemiology, it is quite easy. But to be very honest, on an undergraduate level, it's not that easy to understand. But on an exam point of view, you can easily score marks in epidemiology. But if you're much interested in epidemiology, you can go to internet or other textbooks to learn more about epidemiology. So more knowledge in epidemiology would never go wasted. It would definitely help you in future as a research person. So without much further ado, we'll start with epidemiology. So any essay question will start with these two things, that is defining and classifying epidemiology. Definition, you need to write the John M. Last definition, that is it's a study of distribution and determinants of health related states or events in a population and application of the same to prevent the disease. While coming to the classification, we have broadly 2 classification. One is observational and then experimental. Under observational, we have descriptive and analytical. And analytical is further divided into case control and cohort study. In observational study, the investigator has a role of observer, whereas in experimental study, the investigator not just observing, he is actually intervening. And it is classified as randomized control trial, field trials and community trials. And randomized control trial also has a non-randomized counterpart also. So the first question asked was experimental epidemiology, that is asked many times. Sometimes the question will be of randomized control trial, or mostly it is experimental epidemiology. So experimental epidemiology, which is having 2 branches, that is randomized control trial and non-randomized control trial. It depends on whether randomization is present or not. So it is to provide a scientific proof and as a measuring method to test the efficacy of a drug or a method. So what are the basic steps in RCT, or randomized control trial or experimental epidemiology? So the first step is drawing up a protocol. Then we need to select the reference and sample population. Then we need to do the randomization, that is participants will be allocated into experimental or control group. After that, we need to do intervention, then follow up and outcome assessment. So the protocol is the core of this randomized control trial or experimental epidemiology, that it has everything about the study. It explains about the aims and objectives, the questions to be answered, the criteria for selection of the participants, the sample size, how we are going to allocate subjects into study and control group, the treatment to be applied, and the standardization of working procedures. All those things will be mentioned before the start of study, that is protocol. After that, we need to select reference and experimental population. So before that, we need to take consent from the participant. The participant must be a representative of the population so that the result obtained from the study can be extrapolated to the population. So we need to be very careful while doing the sampling technique. And patient should be eligible for the trials. This is the core of RCT, that is a randomization, where we remove the selection bias, where the participants are allocated into study and control group by any of the method. It can be a lottery method or a computer generated method, and it is known as the heart of RCT. And manipulation, where the investigator intervenes. So in experimental study, the investigator has a clear role rather than the descriptive study. Descriptive study, the investigator just observe things, but in experimental study he has a significant role, that is he intervene the study group by deliberate application, or he applies some vaccine or drug as laid down in protocol. So this manipulation creates an independent variable. Independent variable is a cause, okay, and whose effect is determined by the measurement of final outcome, that is a dependent variable. So the incidence of disease, survival time. So how the independent variable is affecting on the dependent variable, that is the study is all about. After that, we need to wait for some time, that is a follow-up period, how the two groups are acting for the independent variable or the drugs or vaccine, and we should take the or measure the outcome. Sometimes there will be attrition problem, that is loss to follow-up, because some patient might go out of the study and patient might lose the interest and death can happen. So that is an attrition problem in randomized control trial. And finally, we need to assess the result. Sometimes it will be a positive result or negative result. So the types of RCT, there are many types of RCT. The first one is clinical trial, that is the most commonly used. Then preventive trials, risk factor trials, cessation experiments, trial of etiological agents, evaluation of health services. So you need to just mention the names of all of it. So this is the most commonly asked question, experimental epidemiology. So after that, we were studying experimental epidemiology. It has two classification, RCT and non-RCT, which is also known as quasi-experiments. Quasi-experiments, where we have a situation when a randomization is not possible, such as natural experiments, where we can do this non-randomized trial, which is also known as quasi-experiment. We have natural experiment, uncontrolled trials, that is without any control group, and before after comparison studies. Next question is again define epidemiology. You need to write the definition, then describe in detail about the analytical epidemiology. So analytical epidemiology is to formulate, it is to test the hypothesis, whereas a descriptive epidemiology is to formulate the hypothesis. So in analytical epidemiology, we have two broad classification, that is case control and cohort study. So case control is, as a picture shows, first we select people with disease and people without disease. They are known as cases and controls, and we go backward and we ask the cases and controls about their exposure. If they have lung cancer, if they don't have lung cancer, we ask about their exposure, that is the smoking. So how many of the cases were having smoking, how many of the controls were having smoking, and we compare these two groups. So the step one is selecting cases and control, then we need to match, then we need to measure the exposure. Exposure is nothing but the causal factor, and analysis and interpretation. So we need to first select the case. We can select from hospital or general population, and similarly control from the same hospitals or patients' relatives or neighbors, or even from general population. The ideal ratio is 1:1. Okay, we can go 1:4, that is 1 case to 4 control, but ideal is 1:1. After that, we need to do matching. Matching is process by which we select control in such a way that they are similar to cases. but no disease. So usually age and gender matching will be done. If a patient with lung cancer of 25 year and a male patient, we need to select a patient 25-year male but without lung cancer. It can be an individual or group matching, and we need to measure the exposure. So we are asking patients about the exposure status. So it is a retrospective study, we are going backward. So it can be done using interviews, hospital records and past records. Finally, we need to do the risk estimation. So in case control study, the risk estimation is done by odds ratio, that is the odds of exposure, the chances of exposure among the cases versus among controls, that is odds of exposure we are checking. We are not actually calculating the relative risk, we are checking the odds ratio because we are going backward. It is a retrospective study, we don't have clear data, we are just asking questions to the people who already have disease or who are selected as a control, asking about their previous history. Okay, so it is an indirect method of risk estimation. So whereas cohort study, it is a prospective study, that is, it is going forward. Okay, so there are three types of prospective study, that is cohort study. One is prospective cohort study, retrospective cohort study, and the combination of prospective and retrospective. So there is a slight difference in all these things. Prospective cohort study, this is actually speaking cohort study, that is, it starts from 2008 and it is going forward. When the study starts, there is nobody is having disease. So after some period of time, they will be categorized into exposed and non-exposed group. That is, we are selecting a group of college students without any smoking habit. So after a period of time, the college students, that is a cohort. Okay, cohort is a group which shares a common characteristics. That is a college students, that is a common characteristics. So they are automatically divided into smokers and non-smokers, and we follow them for several years, and how many of them are developing disease in each group, and we take the risk estimation. So that is the actual prospective cohort study. Whereas retrospective cohort study, it is a reverse phenomena. It is not like a case control study. We are following back a cohort. Okay, so a historical cohort study it is. It is a prospective study in retrospective manner. So what is doing here is we are taking a historical cohort where the outcome, so in retrospective study, what is the difference from prospective study? The outcome has already occurred. So you might get confused. Case control study, the outcome has already occurred, but what the difference from case control study is, we are following a cohort. Okay, a cohort is a group with a common characteristic, a college students or a group of people with smoking habit. So we are selecting a group of cohort. Cohort means a group with common characteristics, college students or a women in particular age group, and we are tracing back their history. In case control study, there is no cohort. We are just selecting cases and selecting the controls from friends or relatives or general population and asking questions. But here we are tracing back a cohort. Okay. So here the investigator goes back in time, sometimes 10 to 30 years, to select the study groups, that is exposed and non-exposed, from the existing records of the past employment, medical or other records, and traces them forward through time from a past date fixed on the record, usually up to the present, and to check if the disease has occurred or not. So the advantage of this thing is we can still calculate the relative risk but without any delay in the study, because in prospective study we have to wait the disease to happen. The disease might not happen, so all the time, manpower, money would go wasted. And the combination of these two is known as combination of prospective and retrospective study. Okay, so you don't need to worry much about an undergraduate level. You can just write the classification of cohort study, whereas steps similar to the case control, selection of study subjects, obtaining data on exposure, selection of comparison group, follow-up and analysis. So this is a flow chart similar to the case control study, where you remember case control is going backward. Okay, we are asking about exposure status. Okay, exposure status, but what is happening is we are taking a cohort, a population, over a period of time. See, time is going forward. It is a prospective study, forward looking study, whereas this is a retrospective study. Okay, we are coming from here to present condition. Okay, so we are starting from past to present. Okay, here we are starting from present to the future. Okay, So exposed and not exposed. So at the start of the study, people are not having any disease. Okay, in case control we are starting with disease, and after a period of time we follow up these people and checking how many of the exposed are getting disease and how many of the non-exposed are getting disease. So that is a framework. Okay, similar to we need to select the study subject, that is a cohort. It's very important, it should be a cohort, and the data from the cohort members, medical reports or lab investigation. And we need to select a comparison group. It can be an internal comparison, that is within the same cohort. As I said, a college students from the early time, we can follow them. Some will be developing the habit of smoking, they will be the exposed group, and the same cohort meaning will not be having the habit, so they will become the comparison group. Or we can also select an external comparison. And follow up, we need to follow the patient for a period of time with surveillance and medical examination. And finally, calculation of risk, that is the actual risk, that is relative risk can be calculated, attributable risk and population attributable risk also can be calculated. Next question is define epidemiology and explain the steps of descriptive epidemiology. So actually we have three major study design. One is descriptive epidemiology. Actually we are going in reverse order. Descriptive epidemiology, this is to formulate the hypothesis, and the second one is analytical epidemiology. This is to test the hypothesis. We have case control and cohort. And the first one we have experimental epidemiology. Okay, this is to do experiments. The experimental epidemiology where investigator has a clear role, but in analytical epidemiology and descriptive epidemiology the person is not having a clear role, rather he is a just observer. He observes things and do the testing of or formulating hypothesis. So descriptive epidemiology steps are, first we need to define the population where we are going to do the study, then defining the disease under study. We need to have a clear operational definition of the disease, and we need to describe it. This is the most important part, describing the disease under place, where it is spreading, time, how fast it is spreading, and person, how many of the people are getting, in which age groups, in which gender, in which socioeconomic status. All we need to describe and measure the disease with the help of tools of epidemiology, that is in the name of incidence or the prevalence or attack rate or secondary attack rate. We need to measure the disease and compare with non-entices. So we need to compare it with existing parameters. Finally, we are formulating a hypothesis. It is an assumption. Hypothesis is an assumption. So the end of descriptive study is with the etiological hypothesis. It could be the reason for that is smoking, could be the reason for lung cancer. We are explaining it with a could be. So it is not a confirmative statement, it is an assumption, that is hypothesis. And in analytical study, what we do is we can go for a case control study or we can go for a cohort study, and we need to test the hypothesis. This could be will be changed to a relative risk or a odds ratio, that is more confirmative. Okay, so I have not explained the details of all this in written, so each step has to be explained well if it is asked as an essay question. Now lots of short notes, and before that these three main questions can be also asked as a short essay. Okay, so in that time you don't need to explain much, but when you're writing cohort study and case control study, make sure you draw all these flowcharts. Okay, now the prevalence. Prevalence is nothing but all the cases, old and new. Okay, this is a proportion. So it can be a point prevalence or a period prevalence. Point prevalence is old and new cases at a given point, whereas a period at a given period. Okay, point prevalence we take the population, but period prevalence we take mid-interval population. Mid-interval population means if a 1 year period of population we are taking, we take the population of June 1st. That is a mid portion or the mid part or the middle of 365 days. That is a starting of 6 months. July 1st, I mean, not June, July 1st, because June 6 months and July to December 6 months. So that is a mid-interval population. Here we take the entire population. So it is a period of time. This is a point of time. Okay, so yeah, we have an example here. On March, this is red color are the cases. So these 10 persons enter into a study at different point of time, and they develop disease at different point of time. This person 9 developed disease at Jan, and the second person disease, he entered the entered the study with the disease. Okay, this person developed around between Feb and March. So point prevalence on March 1. So on March 1 we have 1, 2 and 3. So 3 orange are there, that is disease. So on March 1st we have 3 cases out of 10. So 3 by 10 is a point prevalence, that is 0.3. Whereas the period prevalence of March to July, so we need to start from here to start from here. So how many are in between these two? Okay, so 1, 2, 3, 4, 5, 6, 7. Okay, so period prevalence of March 7 is 7 by 10. If we take point prevalence of July, it will be 1, 2, 3 and 4, 4 by 10. Okay, so like that. And if we take this May, we get only 1, 2 and 3. So that is prevalence. So denominator will be the total population or mid-interval population. Whereas incidence is a number of new cases occurring in a population. So there is always a period of time, because we need to know how many diseases are happening in how many days or how many weeks or how many months. So we need to know the speed of disease occurrence. So always we mention a period, a time factor is there. Okay, so two types are there: cumulative and incident. Cumulative incidence and incidence rate. Incidence rate is the actual incidence, which is also known as incidence density. So this is another example. In incidence, we mention it as a person year. Okay, so how many period or how many years the person is under risk, that is person year. You just see here. So in person year, so the person number 10 starts from enter the study at second year and he develops the disease at 5 years. So the risk was for 3 years. So he constitute 3 person year. And this 9th, 8th, 7th, 6th all are entering study, or they are being exposed from the year 0. Okay, so patient 9 has 6 years of risk, but he didn't develop the disease, but still he has 6% year. Person 8 also has 6% year. Once the person develops disease, there is no risk. Okay, because he develops a disease. So we are checking only risk period. Here we know the person starts by 3 years and for 3 years. By end of 6 years study stopped. So how many period or how many years the person is under risk, that is what person year. So incidence density, number of new cases, that is 1, 2, 3 and 4. 4 by how many person year? Here 3, 6, all we add, we get total 46 year. This black is death. Okay, this person enters the study at year 1, but by year 5 he died. Still he was 4 year. He has 4 here, 4 person year. So it was, so incident density is 4 by 46.09 per year. So cumulative incidence, similarly, it is a new cases, but the denominator is initial or mid-year population, just like our prevalence. Only for incidence rate or incidence density, we have denominator person time. That is what we calculated here. Okay, that is only for incidence rate or incidence density. Cumulative incidence is nothing but like prevalence, we add incidence plus period prevalence. It's a little complicated, but it is calculating a period. Okay, and for incidence we need to go for cohort study, and for prevalence we need to have cross-sectional study, because cross-sectional is a retrospective or asking past history, whereas cohort study we are taking the new cases, or we are going towards the future. Okay, so that is the difference between prevalence and incidence. You can write, if the question asks prevalence and incidence, the table would be great to get marks. Next is bias. Bias is nothing but a systematic error in research between the exposure and disease. Basically we have 3 bias. One is selection, information and confounding. So we have bias in case control and cohort study. In case control we have selection bias, that is prevalence incidence bias, or which is known as selective survival. So I'll explain you with an example of cancer. Cancer is a chronic disease. A patient starts the disease and he survives a lot of time if he gets good treatment. Still, the natural history is very lengthier. So when we start a study, uh, we take patients who has disease for last 5 years and who develops the disease last year. Okay, so the study includes incident cases, that is the new cases, and also prevalent cases, that is the person with disease for many years of time. And we ask questions to these people and they respond in different way, because the new cases won't be having much to say, whereas the prevalent cases, or the people with disease for such a long time, would answer in a different way, because he was experiencing this problem for a period of time. So that problem creates a bias that is known as prevalence incidence bias. When a study which includes both prevalent cases and incident cases nothing but new cases, prevalent cases is nothing but old cases, that is a disease for a quiet period of time. So that is a selective survival bias. Good. The person's survival is different. If patient gets the treatment at earlier time, he survives a lot of time. If the patient receives the treatment at the end of his natural history, the person might not survive. So this problem always comes with chronic diseases. And admission rate bias is Bergson's bias, which is put forward by Joseph, or noticed by Joseph Bergson. That is when the case control study is done at a hospital. And to be very honest, most of the case control study will be done at hospitals only, because the cases will be at hospital, not in a general population. So the entire concept of cases is not representing the general population. So most of the time, uh, the case control study, the odds ratio what we get from case control study might be overestimated, because the cases are not representative of general population, because we won't find many cases in general population, because cases would be at hospital and they come back to the general population after getting cured. So that is admission rate bias, because we have different proportion of cases of same disease at hospital and general population. That is Bergson bias. Information bias is the bias which is happening while collecting information. So memory or recall bias. In case control study, we are asking patients about their previous history, the information which happened to the patients last year or 2 years ago. So patient would definitely have difficulty in recollecting all the things which happened 2 years ago, 3 years ago. So there will be lots of misinformation or high chances of false information. So that is memory or recall bias, difficulty in recalling the information. Telescopic bias, it is a psychological phenomena. When we ask a question of a recent thing, he might say the things which had happened to him or her very long ago. That is a telescopic effect. So when we look at a thing using a telescope, it might be at a very closer level. So that kind of thing also happens when a patient recollects his answers. And interviewer's bias is a patient, the interviewer is having a suspicion, and he is, when being known the hypothesis, he has a chance to uh, change the answer, okay, or in a way that the things goes in a hypothesis way, because it is definitely doing to test the hypothesis. So a person or an interviewer knows the hypothesis would definitely alter the, or chances to alter the answers. And Hawthorne effect is observer bias. It is a again psychological effect. Hawthorne effect is something like when we are being observed, we try to perform in a better way. When we are in a study, or we know that we are being studied, we answer in a better way, or answer in a way which helps the person to find out the, or test the hypothesis. So we always try to help the person by altering or we present ourselves in a better way. So that is Hawthorne effect. When we are being studied and the patient knows that he is being studied, we alter the responses. Bias due to confounding, or third variable bias. This is a bias which happens in every study, because we study two things basically, independent variable and dependent variable. We are studying coffee drinking causes lung cancer, but there are many things which affects coffee drinking and lung cancer. Okay, they are confounders or concealing variables. They affect both independent and dependent variables. So we need to include as many explaining or confounding variables in the study to reduce the overestimation. Otherwise, the odds ratio we get will be very much high. If we get odds ratio of 10, that says that person who drinks coffee is having 10 times risk of having lung cancer uh, compared to the people who is not having the habit of drinking coffee. But that is not true. That is because many other variables are involved in the study. So the person who is drinking coffee will be having a chance of smoking because they are linked always. So this is not being tested. So we need to include third variables so that the actual effect of the variable would be expressed. Whereas in the bias in cohort study, similarly, it is a forward-looking study, so there will be chances of non-consent bias or missing data bias. The person who said yes at the beginning, but he might refuse in later time, and missing data bias, that is a follow-up study, so there are high chances of data missing because we need to follow up the person over a period of time. So high chances of data missing. Then information bias like misclassification bias or diagnostic bias, and similarly confounding bias also can happen here. Whereas a postdoc bias, we are doing a study, and that is a cohort study for a very long period of time. So at the end of the study, we are not getting the result we wanted. So what we do is we do dredging on the data, which is actually giving no result, but we do more dredging, and we get something which is useful for our study, which is actually not true. Okay, so that is postdoc bias. We do dredging and we get a result we wanted. Blinding is three types. So blinding is to avoid the participant or investigator known which group are they belong to, or to mask the doctor or the investigator where the participants or which participants are receiving which drug. That is blinding. It avoids bias. So randomized control trial or the trials always follow double blind or triple blind or single blind. In single blind, the participants would not be knowing which drug they are receiving. Double blind, both investigator and participants are not knowing which drug he is giving, because the third person would give the drugs to the participants. And triple blind, the person who is doing this data analysis, that is a statistician, also will not be knowing which group data he is analyzing. That is blinding. Time trends comes in the descriptive epidemiology. That is disease with short-term fluctuation, periodic fluctuation, long-term fluctuation. It has got details in the chapter, epidemiology chapter. It is not very frequently asked, but time trends, it is a little confusing term, so we don't get confused. Time trends is coming in descriptive epidemiology in describing the disease under time, how the disease are getting fluctuated. Some are short-term, some diseases are periodic, and some are long-term diseases. Matching we already discussed in case control study. We have pair matching and group matching. Pair matching, we know a person with this gender, a person with this gender but without disease. Group matching is if we have 25% married, we select 25% unmarried. Odds ratio is nothing but the odds of exposure in cases by the odds of exposure in control. Okay, so we need to draw a contingency table exactly like this. Disease and non-disease, that is case and control, should be on the x-axis. Exposed and unexposed should be on the y-axis. So odds ratio is nothing but the cross product, that is AD by BC. So odds ratio gives that is, if odds ratio is 5, that says that the control or the cases, the exposure in the cases is 5 times to the control. That is, if patient with lung cancer is having 5 times odds ratio to the person without lung cancer, and smoking is the other variable, means person who smokes has 5 times chance of developing this lung cancer compared to the person who doesn't smoke. That is the odds ratio. It is a risk estimation in case control study, whereas the relative risk is the actual risk. It is the incidence of incidence among exposed and incidence among unexposed. This is the incidence A and C. Exposed is A plus B and unexposed is C plus D. So A by exposed, A by B, C by unexposed, C by D. So incidence in exposed and incidence in unexposed. So this also says that if a study reports a risk of 5, relative risk of 5, a person with smoking habit would develop lung cancer 5 times compared to the person who is not having the habit. So the risk compared to the unexposed group. Whereas attributable risk is incidence among exposed minus incidence among non-exposed divided by incidence among exposed into 100. This says the percentage of attribution to that particular causal factor. Suppose we get 30% means if a group of people, 100 people smokes, the 30 people would get the lung cancer. And if we have attributable risk 70%, the 100 people is having the habit of smoking, 70 out of this 100 would get the outcome or lung cancer. That is attributable risk, how much power the particular causal factor has. Whereas population attributable risk is incidence in total population minus incidence among the non-exposed divided by the incidence of total population. This is applicable in preventive experiments. If we remove the smoking from that population, this percentage of people can be saved. If this risk and this risk will be in, these two are in percentage. This attributable risk explains the power of a causal factor, but this says if we remove that particular causal factor from the population, that is, if we are implementing a tobacco cessation program in a group of people, we can save 30% of death. So if we get 40%, if we remove the causal factor, or if removal of causal factor is nothing but cessation or tobacco cessation or changes in the habit. So that helps to understand the power of a experiment or a preventive strategy. First we need to calculate the population attributable risk. Okay, so that particular the causal factor is removed from the population, how much or how percentage of people can be saved. Now the principles of epidemiology, we have 4 principles of epidemiology, that is exact observation, correct interpretation, rational explanation, and scientific interpretation. We have acronym every coffee requires sugar. So principles of epidemiology, earlier we learned principles of primary healthcare, that is community participation, intersectoral coordination, equitable distribution, and appropriate technology. But this is principles of epidemiology. Again we are having principles of health education next session. And tools of epidemiology, rate, ratio, and proportion. Rate, we already seen. Incidence is a rate, death rate, birth rate, over rate, run rate. So rate is always having a time frame in the denominator, whereas a ratio, there is no connection between numerator and denominator, the male female ratio, doctor population ratio. Proportion, there is always connection with numerator and denominator, that is 30%, 40%. Incidence is rate, whereas a proportion is prevalence. Prevalence is how many people out of the population is having disease. So prevalence is an example of proportion, incidence is an example of rate. So this is a difference between case control and cohort study. Case control, it starts from effect to cause. This is cause to effect, that is lung cancer to smoking. So how many of the people with lung cancer, when without lung cancer having the exposure, that is smoking, and we take odds ratio. Here we are starting with smoking to lung cancer. So this starts with disease, this starts with people exposed to the risk factor, and it involves very few subjects because already we have case. Just select the control and do study. Here it involves large number of subjects, long follow-up, delayed result. It will give result very easily. This is suitable for rare disease because already happened, so we just need to take the control. But this is not at all appropriate for rare disease because rare disease occurs rarely. If we start the disease and we are waiting for those disease to occur, that might not ever occur, and we end up with losing all our money, time, and workforce. So cohort study is always give result for very common diseases like cardiac diseases, blood pressure diseases, lifestyle diseases, which is happening to everyone. And this is giving odds ratio, this is relative risk and attributable risk. This is inexpensive, this is very expensive. So that the difference between case control and cohort study. Okay, so that was all about epidemiology. I was not explaining everything, but I think to an extent I explained. So you need to write the steps of descriptive study, analytical study, and experimental study with flow chart to get good marks. And when you're writing case control and cohort, always include this table. And this rate, ratio, proportion is always asked, but mostly asked question is prevalence and incidence. It's very confusing thing when it comes to types of incidence and types of prevalence. So if you pay attention for a little period, you will understand both prevalence and incidence in depth. And bias is always asked question, so make sure that you write both case control bias and cohort bias. Rest are easy. So this is very important, not just for exam purpose, in your future also. you definitely be benefited if you study well epidemiology. Okay, so next session we have third session. It's about epidemiology of dental caries, periodontics, and oral cancer. It's a quite simple chapter, but questions are asked frequently. So I'll come up with this part 3 in my next session. Thank you.